Good afternoon, everyone. Welcome to Medicaid Financing of Early Childhood Home Visiting Programs National Webinar. My name is Karen Van Landeham, and I'm a Senior Program Director at the National Academy for State Health Policy. And we're delighted you're able to join us this afternoon for what we hope is a very interactive and enlightening webinar on the topic of home visiting. The purpose of today's webinar is really threefold. We'd really like to highlight opportunities to promote and cover home visiting services for pregnant women, infants, and children and their families, discuss opportunities and challenges to leveraging Medicaid coverage of home visiting services, and then really outline strategies and approaches that leading states are using to advance and cover home visiting services through Medicaid. I want to take a brief moment to thank the Alliance for Early Success for their support of this webinar and also for their support of a national report on the same topic that NASHP just released about a month ago. So a few logistics. Everyone should be dialed into this webinar. All lines are muted. We really want this webinar to be interactive, so we encourage you to ask questions. But because your lines are muted, we ask you to ask your questions through the chat box function. There'll be several opportunities for question and answer throughout the webinar. I'm going to pause after every state speaker to allow for any kind of clarifying questions of the state presentations, and then we have time at the end of the webinar for some interactive discussion. So again, please be jotting down your questions as you listen to the presentations, and please feel free to chat those in the chat box, and we'll get to as many as we can. So I just want to briefly introduce our presenters today. Our first presenter is Becky Normile. She's a policy associate who works on child health issues at NASHP, and she was one of the lead authors of the recent NASHP report that was released on Medicaid coverage of home visiting services. We'll have information about that at the end of the webinar where you can get that if you haven't seen that already. Becky's going to provide a brief overview of some of the issues we featured in that report, including mainly how many states are financing home visiting through Medicaid and other means. After Becky, we're going to hear from Vanessa Brewer. She's a health policy specialist with the HANDS program at the Kentucky Department for Public Health. Vanessa has been with the HANDS program for 11 years, where she has served as a state training coordinator, regional technical assistance team coordinator, and HANDS program lead. After we hear from Vanessa talking about the work in Kentucky, we'll then have two presenters from Michigan. Our first presenter from Michigan is Suzette Burkett Weselek, and she's the Quality Improvement Coordinator and Acting Program Coordinator for the Maternal Infant Health Program with the Michigan Department of Health and Human Services. She has over 30 years experience in the healthcare industry in maternal and child health, managed care, case management, and many other areas. Following Suzette, we'll hear from Marie LaPrey. Marie is the manager of the Practitioner Services section of the Program Policy Division within the Medical Services Administration of the Michigan Department of Health and Human Services. Prior to her work in program policy, Marie was a Medicaid utilization analyst with the Bureau of Medicaid Operations. She is responsible for several Medicaid program coverage areas, including maternal and child health, family planning services, and physician provider services. And then last but not least, we're going to hear from Kay Johnson. Kay has been a leader in maternal and child health policy for over 30 years. She is currently president of Johnson Group Consulting, a national firm which provides policy research, process facilitation, and case studies on child health policy and financing issues. Her expertise encompasses a range of issues including perinatal and preconception care, immunizations, home visiting, and early childhood development. So just a little bit about NASHP, if you're not familiar with us, the National Academy for State Health Policy. We're an independent academy of state health policymakers working together to identify emerging issues, promising practices, and to develop policy solutions and improve state health policy and practice. We're a nonprofit, nonpartisan organization and dedicated to helping states achieve excellent in-health policy and practice. And we do that in several ways, including sponsoring national webinars like this one. So I just want to say a little bit about home visiting just to set the stage before turning this over to Becky. We know that states have long invested in home visiting as a strategy to support the health and well-being of women, children, and families. We know that home visiting provides voluntary home-based social, health, and educational services to pregnant women and families with young children, typically targeting the most vulnerable communities. And we also know that evidence-based home visiting programs have been shown to be cost-effective interventions with far-reaching impacts. Some of those outcomes include, but are not limited to, improved maternal and child health outcomes, the prevention of child abuse and neglect, helping parents develop positive parenting skills, and promoting healthy child development and school readiness. We also know that evidence-based home visiting programs have been shown to show a return on investment, with some studies showing up to nearly $6 saved for every dollar invested. And those cost savings are attributed to areas including reductions in emergency department visits, decreased special education placements and grade repetition, and just overall greater economic success later in life for those who have participated in home visiting programs. So again, we're just very excited about today's topic, excited to hear more from each of our state presenters. And before that, I'll turn this over to Becky Normile, who's going to give some background on Medicaid financing of home visiting. Becky?
Thanks, Karen. So before we dive into Medicaid financing of home visiting, we just want to first acknowledge that Medicaid is just one of numerous funding streams that states use to support home visiting program, and they typically use a mix of private and public funds. So on the public funding side, there's still a range underlying that. So there's the Maternal, Infant, and Early Childhood Home Visiting Program, Title V Maternal and Child Health Services Block Grant Program, TANF, Child Abuse Prevention Funds, state general funds, and of course Medicaid. And some of these funding sources are in flux, most notably MICV. As I'm sure many folks on this webinar know, MICV is a federal program that expired on September 30th, and Congress has not yet reauthorized it. And so that we know that this can also make talking about financing of home visiting even more challenging. But this also underscores the importance of leveraging multiple funding streams to sustain and expand these crucial programs. And for the purposes of today's webinar, though, we're going to focus on Medicaid's role in home visiting programs. Okay. So when we talk about Medicaid financing of home visiting, it's important to understand the difference between home visiting services and home visiting programs. So home visiting services are discrete medical, behavioral, or educational activities provided in the home setting. And based on a recent survey that Kaiser Family Foundation did, there's at least 33 states that have reported providing home visiting services as a Medicaid benefit to pregnant women, infants, and children. But then there's also home visiting programs, which Karen has already touched on in terms of the evidence-based home visiting programs, but they provide a more comprehensive set of health, social, and educational services, and they typically include screening, case management, and family support and counseling. And just through our research at NASHP, we identified 15 states that are using Medicaid to support those more comprehensive and robust home visiting programs. And there may be more out there, but those are the ones that are just the number that we identified as part of our research for the issue brief. And as many of you likely know, when you talk about Medicaid, there's a set of mandatory services that state Medicaid programs must cover. So you can see those listed on the left-hand side of your screen. And these include services like hospital visits, family planning services, and physician services. And then there's also a set of optional services that states can opt to cover through their Medicaid program. Examples of some of these optional services are listed on the right-hand side of your screen. And these include things like case management, dental services, and private duty nursing. States define which services of those optional services they will cover in their state Medicaid plan, which is approved by CMS. And then essentially when you look at this list, you'll see that home visiting is not listed here. And that's because home visiting is not a mandated or fully defined set of services under Medicaid, which can make the Medicaid financing a bit complex. Certain Medicaid benefit categories will only cover certain services that are provided as part of a home visit. So for states that are pursuing Medicaid support of home visiting programs, they need to consider multiple factors. So they'll need to define one or more benefit categories to cover different services provided as part of a home visit, and then, of course, consider which specific services the benefit category is able to cover. And then if the benefit category is not already included in the state plan, the state will need to submit a state plan amendment or a Medicaid waiver in order to have the authority to cover those services and reimburse for them. And so we know that there are numerous Medicaid financing mechanisms that states are using to support home visiting program. Between this slide and the next, we will just briefly touch on the most commonly used Medicaid financing mechanisms that states are using to support home visiting programs. But we're only going to briefly touch on them here. And for folks that want more information, you can check out our issue brief, which has a table that's a little bit more in depth and provides a closer overview of these different financing mechanisms. But in brief, through all these mechanisms, there are certain advantages and limitations when it comes to their role in supporting home visiting. For example, on this slide, we briefly touch on 1115 waivers and 1915B waivers. In both cases, these waivers allow states to waive certain federal requirements. And so when it comes to home visiting, that allows them to target home visiting programs to certain populations or geographic regions, which is the route most states want to go because they want to limit it to certain populations of pregnant women. But then on the flip side of that, these waiver programs take a lot of time and staff and resources to develop. They also require extensive review, and they also are only effective for a limited number of years. So you can see there's certain trade-offs there. And then on the next slide, we highlight several other benefit categories that states are using to support home visiting programs. So these are some of the commonly used services. So you have something like early and periodic screening, diagnostic, and treatment, or EPSDT, and which is a benefit that covers a comprehensive set of services for children under 21. And EPSDT allows states to cover services that are deemed medically necessary, even if they are not included in their state plan. And so EPSDT would allow states to cover services like screenings, case management, and counseling, all of which are key components of home visiting programs. And through EPSDT, all these services can be provided in the home. And so you'll actually hear Michigan touch on EPSDT later on in this webinar. And then just one other benefit category I wanted to briefly touch on is targeted case management. So targeted case management is an optional benefit that can be used to assist Medicaid enrollees in gaining access to needed medical, social, and educational services. States have a long history of using targeted case management to help ensure pregnant women are able to access prenatal care. And now we're seeing that this is the most common financing mechanisms that states are using to support home visiting programs. And this is something that you'll also hear more about as part of Kentucky's presentation later on. So in addition to those specific financing mechanisms, we're seeing states leverage opportunities to support home visiting programs as part of their health system transformation efforts. As part of these efforts, states are redesigning how care is delivered and paid for, which is creating more flexibility in what services are provided to Medicaid enrollees. And so in the next few slides, we're going to explore how states are starting to incorporate or integrate home visiting programs into these different health system transformation efforts, touching on Medicaid managed care, value-based payments, and accountable care organizations. So just starting with Medicaid managed care, we know that nearly all states are using some form of managed care, and there's also a variety of models of managed care that states have in place. But they typically entail managed care organizations providing a defined set of services to Medicaid enrollees for a monthly capitation rate or per member per month payment. We've seen several examples of states that have integrated home visiting into their Medicaid managed care program. One is Minnesota, and in this case, the state requires its managed care organizations to contract with local public health agencies to provide home visiting services. And then there's also Virginia, and in this case, several of the home visiting programs in the state contracted directly with their Medicaid managed care organizations, and the Medicaid managed care organizations are reimbursing the home visiting program for Medicaid eligible services. And so in this case, it is not a requirement that the managed care organizations contract with the home visiting program. The managed care organizations just opted to do it based on the return on investment that they saw through these programs. And then one last state that you'll hear more from later is Michigan. And then there's also value-based payment, which are definitely growing as more states are trying to shift away from fee-for-service systems. So through value-based payments, Medicaid will link provider payments to performance and outcomes. There's different types of value-based payments, which includes enhanced per member per month payments that are linked to performance, bundled payments, which cover a discrete set of services associated with treating a specific condition, and population-based payments, which is where a group of providers are responsible for delivering care to a specific population for a defined amount of money. One example of a state that has integrated home visiting into its payment and delivery system reform effort is New York. New York is implementing a delivery system reform incentive payment waiver program, or DSRIP, and this is designed to restructure how services are delivered to Medicaid enrollees while moving the state to primarily value-based payments. And through DSRIP, New York has created a variety of networks of providers, and each network is responsible for implementing several projects that are all designed to deliver or to transform the health system and improve population health. And one program that these networks can opt to implement is evidence-based home visiting. And then if they implement this program, the providers can receive incentive payments for reaching specific performance goals associated with the project. And then finally, there's accountable care organizations, or ACOs. And ACOs are a group of providers that have agreed to be accountable for the coordinated care of a given population. And in most cases, ACOs are receiving population-based payments, which I briefly touched on the last slide. And so essentially, the ACOs are offering greater flexibility in covering services not traditionally covered by Medicaid, or allowing programs like home visiting to be built into global budgets. And again, so it's just kind of creating that room to cover home visiting programs in a way that they might not have been able to in the past. And so far, we haven't found an example of a state that has integrated home visiting into their ACO models, but we do know that states are looking into it, and especially as we see accountable care organizations grow or spread, there will likely be more conversations in that area. And so then, before we hear from our state presenters, we just wanted to highlight some of the kind of key findings or takeaways we found through our research as we worked on our issue brief. So we know that supporting home visiting through Medicaid can be complex, but we have seen states successfully do it for years. And we've seen several key considerations that go into their efforts when they're considering how to use Medicaid to support home visiting. So first, states need to determine if they have the authority to cover certain services under their current state plan, and if not, they also need to factor in whether they have the capacity to develop a state plan amendment or a waiver. They also need to consider their home visiting model in their state and which Medicaid benefit categories best support that model. And then also in all states that we researched, Medicaid was just one source of funding for home visiting programs. So when states are looking to use Medicaid, they really need to consider how to coordinate and align Medicaid with the other funding sources that are supporting the state's home visiting programs. And so overall, we know there are numerous financing mechanisms available through Medicaid, but which mechanism states use really depends on their unique environment and the considerations that we just walked through. And we also know that when states are supporting home visiting programs, they are using multiple funding streams, not just Medicaid. Medicaid can cover specific services provided through home visiting programs, but there's other kind of costs associated with training home visiting providers or administrating the programs that Medicaid will not be able to cover. So it's important to consider how Medicaid fits together with those funding sources. And so partnering and collaborating with Medicaid is crucial to developing, implementing, and sustaining home visiting programs that really meet the needs of your target populations. So you'll hear a little bit more from Kentucky and Michigan in terms of their collaboration efforts. But again, it's just critical if you're looking to use Medicaid to really develop those partnerships and ensure that you're maximizing your resources to support the populations in need. And then finally, we just made to make sure everyone had links. So here you'll see the link to our current issue brief, which we just released this year. But this issue brief really built on some work that was done by NASHP in 2012, which was a kind of more lengthier and deeper dive report that we have since kind of refreshed, but just so folks can access that, there's a link for that as well. And so with that, I'll actually turn it over to Vanessa Brewer, who's the Health Policy Specialist with the Kentucky Department of Health. Vanessa? Vanessa, you may need to unmute your line.
While we're waiting for Vanessa to unmute her line, this is Karen Van Landehem, and we did get a question, an overall question in the chat box about when we're talking about home visiting, are we talking about only home visiting that's funded by MICV, the Maternal Infant Early Childhood Home Visiting Program? And just to clarify, when we're saying home visiting, we mean home visiting broadly. I think a lot of what we're talking about today is really evidence-based home visiting programs, but what we're really talking about is home visiting broadly to include those programs funded by MICV, but also funded by other funding sources. So just wanted to clarify that. And let me see, Vanessa, have you joined us? Are you unmuted? So we may be having some technical difficulties. I'm wondering if we can have the Michigan folks go next, and we'll come back to Vanessa's presentation and hopefully in that time get her sound working.
Sure. This is Suzette Marie. We're happy to go next.
Thank you, Suzette.
Okay. As I just said, this is Suzette Burkett-Westlock with Michigan. I'm going to speak first and just briefly cover some information about our maternal infant health program, home visiting, and some of the goals, some of the research that's been done, and a little bit about our services. Michigan has several home visiting programs that are funded through maternal infant early childhood home visiting. The largest home visiting program in Michigan is funded through, next slide, thank you. The largest home visiting program in Michigan is funded by Medicaid, and this is the Maternal Infant Health Program, or we call it MIHP. MIHP is available for pregnant women and their infants through age 1. Services are delivered by a professional staff in over 100 provider agencies throughout the state. And we have a validated risk assessment that is done on the first visit, and the beneficiary or primary caregiver's answers are entered into the state's database. And then an algorithm produces the level of risk for several of these domains. And that's what we address. Just a couple examples of the domains include chronic health conditions, behavioral health, family planning, domestic violence, infant safety, breastfeeding, and some others. From March of 2016 through March of 2017, we served 22,286 pregnant women and 24,456 infants. And that was just alone in our MIHP program. Next slide. The MIHP is administered collaboratively by the Michigan Department of Health and Human Services Medical Services Administration and the Population Health Administration. And the collaboration really allows Medicaid beneficiaries the support needed to promote healthy pregnancies, positive birth outcomes, and healthy infants. Next slide. A little bit about our history. In an effort to reduce infant mortality and morbidity, Michigan started the Maternal Infant Support Service and Infant Support Service Home Visiting Program in the late 1980s. And this was funded by Medicaid, and it was for Medicaid beneficiaries. The providers that provided the services were given a broad leeway in determining how services were delivered, and this resulted in a great deal of variation. Then in 2004, there were some studies done, and we decided to redesign the program based on these results and the stagnant state infant mortality rate. So we really wanted to get to an evidence-based, outcome-based population program. And that is what the goal of the redesign was and what we have thankfully proven it to do. 2009 through 15, researchers from Michigan State University evaluated our program and conducted the research needed to prove MIHP as an evidence-based program. And then this still continues today. We have a nice evaluation and quality improvement program, and current literature regarding our issues, the issues that MIHP beneficiaries face are embedded into the program. Next slide. So these are our current goals. I'm not going to read them to you, but just mainly promoting healthy pregnancies, healthy birth outcomes, healthy development for infants, and then our long-term goal is to reduce infant mortality and morbidity among the Medicaid population. Next slide. A bit more about, I'm getting back. Is anybody else? Okay. A bit more about the research for our program. The researchers began with 2009 data from the program and utilized a quasi-experimental design rather than a randomized or true experimental design for the study. Since all pregnant women and infant beneficiaries with Medicaid in Michigan are entitled to MIHP services, we could not randomly assign. So to add to the robustness of the research, a propensity score matching design was also utilized in this research. Next slide. So the research findings have been very positive in certain areas of our program. As you can see on the slide, there's strong evidence for the effectiveness of a Medicaid-sponsored population-based home visiting program. The results show the program improves maternal and infant care. Prenatally, the beneficiaries are more likely to not only obtain care, but obtain the adequate number of prenatal visits that are recommended. And moms in MIHP are also more likely to present for that postnatal checkup within that recommended time frame. Next slide. Infants receiving MIHP services are also more likely to present for well-child visits and adhere to the recommended number of well-child visits during the first year. And then participation in MIHP has reduced the risk of infant death, most significantly in the neonatal and postneonatal period. Next slide. So what we see here is that MIHP reduced the risk for adverse birth outcomes with a particular advantage for Black women. The researchers also looked at the dosage of the program, and that's the amount of visits, and found that enrolling in the first 2 trimesters and receiving the risk screener, which is our assessment, and at least 3 additional home visits decreased the likelihood of having adverse birth outcomes. And not only for women of all races, but even more robust for Black women. So for further information, I've included the publications at the bottom of this slide. Hopefully when they're sent to you, you can see it. If not, you'll have my contact at the end, so you can email me for that or Google it. The next slide, please. So our researchers and our MDHHS, our Michigan epidemiologists, also did a return on investment. So in 2015, they published a return on investment fact sheet, and the ROI showed cost savings to Medicaid by looking only at the reduction in preterm birth rates. I know we had a slide earlier that showed looked like maybe more lifespan, but this was only looking at reduction in preterm birth. And they found that for every dollar spent on prenatal MIHP services, Medicaid saved $1.38 in costs associated with preterm birth in that first month of life. So the assumption is that the return on investment would increase if more items were looked at and as more mothers enroll in the MIHP program. The next slide, the services that we provide through MIHP include case management that's implemented by registered nurses and social workers. And then we have an evidence-based interventions through our plan of care. We also have dietitians and infant mental health specialists, as well as board-certified lactation consultants that provide services. And then lastly, we also have childbirth and parenting education classes that are covered through this program. And now Marie's going to discuss Medicaid funding and program requirements.
Yep, on the next slide, please. Thanks. When states are using a Medicaid state plan authority such as Michigan as a funding source for their home visiting services, as we mentioned earlier in this presentation, states do have a lot of flexibility as they design their programs. We attribute here in Michigan our home visiting services for the MIHP program to two areas. One is extended services to pregnant women, and the other, for the infants, we use the authority under EPSDT. In our state of Michigan, the entire program covers 2.4 million lives. It's kind of a large program, I would say, for many states. And we, the Medicaid program here in Michigan, pay for approximately 47% of the live births in our state. Next slide, please. When providing home visiting services as a Medicaid-covered benefit, using state plan authority, we are required to take into consideration multiple federal regulations, and our MIHP program does align with those. For example, Medicaid beneficiaries must be permitted to choose a healthcare provider from any qualified provider who undertakes to provide the services. Services have to be, under the state plan, have to be available statewide to all eligible individuals, and in the case of the MIHP, there is a presence of that program in every county in our state. Medicaid-covered beneficiaries or benefits must be provided in the same amount, duration, and scope to all enrollees. So, for example, if a state wanted to provide a home visiting service to address the needs of pregnant women, it would have to, just like MIHP, make these same services available to all pregnant women who need the services. And all these services are cost exempt under federal provisions. Next slide. The coordination between our MIHP and our Medicaid health plans and our medical care providers has been very key to the success of our program. In the state of Michigan, pregnant women and infant Medicaid beneficiaries, for the most part, with few exceptions, are required to enroll in our Medicaid health plans. We contract with over 11 health plans in our state, in various geographical areas, overall 83 counties. And over the years, Medicaid has consistently encouraged our MIHP providers and our Medicaid health plans to have a coordination of all the benefits and coordinating the important aspects of the maternal and child dyad. One of the ways that we foster that is through the Care Coordination Agreement, which is something that we've had in place and a requirement between our health plans and our MIHP programs. It's a document that describes the services and essential aspects of the collaboration between the two providers. The other aspect of our program is that under the MIHP, our MIHP providers are required as a program expectation to notify and keep an ongoing communication with the beneficiary's medical providers. For the most part, and for many years, the MIHP program has been outside of our managed care contracts, and as of January of this year, we actually brought them back in under the contract. So the transition of having the health plans pay for and administer the MIHP services, there was a big concerted effort by all of the parties to kind of coordinate all of this. Communication is absolutely key to make sure both in planning and issue resolution for everyone. So that was a big project for us. Next slide. For a few insights that we might have for any state who is thinking about starting or expanding their home visiting services under the state plan authority, we have a couple of areas that we think have played a pretty significant role in the success of our MIHP. First of all, any successful program, regardless of your funding stream, will really need to include a significant investment in the development of partnerships with a variety of stakeholders to foster collaboration amongst all of them. We have internal and external partners advocating on behalf of positive maternal and child health outcomes. Internally, our Michigan Department of Health and Human Services is a very large department, but within there, I work in Medical Services Administration. Suzette, she works in the Population Health In the Division of Maternal and Child Health, we work with WIC in our department, we work with epidemiology, and we work with our behavioral health, just to name a few of the areas. We also work with our external organizations, and such as our Michigan Association of Health Plans, Michigan Council of Maternal and Child Health. We work with our hospital system providers and a variety of local health and federally qualified health centers, and not to mention our universities, as we've already commented on. Additionally, it's really important for us to integrate with our other statewide programs and initiatives that address this population, both for just the Medicaid population as a whole, as well as the subset of the maternal and infants that are covered by our program. Providers' education and support has been one of the key aspects of our program. We provide our MIHP providers the certification requirements and assistance. We have consultants that function in advisory roles to guide them through the provision of home visiting services. We've created an electronic database which is established to improve the information sharing among our programs, and we also use it to improve our ability to monitor our programs and evaluate program outcomes. Developing a strong collaborative approach to program quality assessment and performance strategies foster goal alignment and make things a little bit easier, and always moving to improve our program and outcomes. And in terms of program evaluation, Suzette already mentioned in earlier slides, our formal evaluation of the MIHP has been an important aspect, and it actually validates and supports the efforts that this program does do throughout the state. And actually putting into perspective the money spent behind this in terms of Medicaid expenditures has really contributed to the overall Medicaid program and the cost savings. But the aim of all of our MIHP evaluations is obviously to continue to assess and improve the quality of care and services that we provide to our Medicaid-enrolled women and infants. Next slide. Thanks for the opportunity to let us tell you about our program. And here's our contact information should anybody have any additional questions or follow-up information. Thank you.
Thank you so much, Suzette and Marie. It was really helpful to hear all of that, and we'll have time for further question and answer at the end, but I have a few clarifying questions that have come in through the chat box. So one of them is kind of an overall question about Medicaid and managed care organizations, and I'm hoping, Marie, you might want to weigh in on this, but there's a question about when a state requires an MCO to provide home-based services via MCO contracts, does the state first have to receive federal approval to do so via a state plan amendment or other mechanism? So do you want to comment on that at all?
I can try, but what I want to say is that I don't work in the managed care division and not familiar with all of the actual requirements that our managed care division does, so they would be our best and most true experts on that. From our perspective, we have had the state plan authority for quite some time, far before we actually moved it into the state plan or into our state contracts with our MCOs. So I'll just be able to speak to that because we were able to incorporate them. I believe, if I'm not mistaken, there are other types of services that we've incorporated into contracts, not the home visiting per se, that are not necessarily based on a state plan authority, but I would hazard to guess that CMS, looking at covered services such as this for infants or women, they will require some type of either state plan authority or waiver authority to make sure that the contracts are properly reimbursed and the rates for the payments.
Yep. Thank you very much. We have another question about MIHP. Is it a universal home visiting program, and is there an evidence-based model that you're using for MIHP?
This is Suzette. It's not a universal program. It's a kind of a homegrown program from Michigan. Our state enacted legislation that any home visiting program in the state needed to be evidence-based. So we did not need the McV funding per se because we have Medicaid. Medicaid pays for this program. So when our researchers started looking at the evaluation of the program, they were looking at it as an evidence-based program for our state. However, they used the McV guidelines when they did the research, and so I don't know if that helps or not, but it is a program that is a Michigan-specific program. Do you want to add anything, Marie?
No.
Okay.
Great. And then we'll have one more clarifying question, and then I'll save, there's some other questions here, but we'll save those for the end because I think Vanessa's back on. But just our final clarifying question, or question specific to Michigan, is just around, you've done some cost-benefit analysis, return on investment, and someone has asked if you happen to know what is the cost per family or beneficiary for the MIHP program.
The cost per
per family or per beneficiary. And maybe you haven't done those breakdowns, but
well, as part of the cost-benefit analysis that they did for the ROI, which I don't have the documents in front of me, I believe they figured out the average cost to the state. So we will look.
Yeah, if we can look to see if we can find it, and maybe get back with everybody.
Sure. Thank you so much.
Okay.
All right. Well, we will we will have further questions for Suzette and Marie at the end, and thanks again for that great presentation. I'm now going to turn this over to Vanessa, who's with the Kentucky HANDS program.
Hello.
Vanessa?
Can you guys hear me?
We can hear you. Thank you.
Hey, thank you. We can go on to the next slide. All right. I'd like to begin with an overview of the HANDS program. HANDS is an evidence-based, statewide home visitation program that provides assistance to overburdened parents during the critical first months of life while the baby's brain is being hardwired. Services are provided regardless of income, and the program is designed to improve both health and social outcomes. Next slide. The goals of the program include healthy pregnancies and births, optimal child growth and development, that children live in healthy and safe homes, and family self-sufficiency. Next slide, please. HANDS believes that all families have strengths, that all parents want to be good parents, that families are responsible for their children and also the primary decision makers regarding their children, and that prevention and early intervention improve the community's well-being. Next slide. The target population for HANDS services includes first-time expectant parents, first-time parents that are seeking adoption, and first-time parents with infants 12 weeks of age or less. Next slide. Anyone can make a referral to the HANDS program. Kentucky has worked really hard to educate and inform community partnerships and organizations throughout the state about the program to increase awareness and referrals. And we also require routine community outreach by our local implementing agencies to promote awareness. Next slide. Once a referral has been made, the HANDS site will determine if the family is eligible for home visiting services through a formal screening and assessment process that assesses the presence of various risk factors associated with increased risk for child maltreatment and other adverse childhood experiences. Referrals are made based on needs identified during the assessment process, and families that assess positive are offered weekly home visitation within 1 week of the assessment. Next slide. During home visitation services, home visitors work with families to establish medical homes for both mom and baby and to maintain up-to-date immunizations and well-child appointments. And the home visitors also discuss injury prevention and complete developmental screenings on each child. And referrals are made as needed based on identified needs and followed up on at the next scheduled home visit. Next slide. Next slide, there we go. The program requires that home visitors use a parent-child interactive curriculum called Growing Great Kids, which focuses on basic care, child development, nurturing parent-child relationships, and strength-based support to families. Each of the modules is designed to support learning by anchoring the information in activities and interactive discussions. And modules support research-based information about brain development, the importance of early language development for school success, the urgency for children's safety, the benefits of connecting families to others in the community, and the critical need to develop empathy with children. Next slide, please. In addition to the health and social focus, home visitors work with families to establish goals to guide families towards improved self-sufficiency. Goals are developed within the first month of services and updated every 3 months, and the home visitor follows up with the family on their progress with their goals during each visit, providing support and referrals as needed. Next slide. And we'll skip the next slide for time's sake. Just some quick facts about the program. HANDS is the only statewide home visiting program in Kentucky. In fiscal year 17, over 10,000 families were served, and over 206,000 home visits were provided throughout the state. On average, 17,639 home visits are provided each month. Next slide. The state has invested in multiple studies that document the effectiveness of HANDS services. The program's strong track record of success has helped the program to retain funding. The latest study conducted by the University of Kentucky Research Foundation showed that HANDS participants were more likely than comparable families to have adequate prenatal care and less likely to have pregnancy-induced hypertension and maternal complications during pregnancy. Next slide. HANDS participants were also less likely than comparable families to have low birth weight infants, deliver prematurely, and to have an infant die shortly after birth. In addition, HANDS participants had less substantiated reports of child maltreatment. Next slide. Additional outcomes include lower rates of infant mortality and emergency room visits, and also employment increased for parents from 14% at the beginning of services to 28% at the end of services. Next slide. One of our proudest moments in HANDS was October 2015 when HANDS was recognized by the Department of Health and Human Services as an evidence-based early childhood home visiting service delivery model. We are one of 18 models that have met the criteria for evidence of effectiveness, and we could not have done this without the support of the Kentucky Cabinet for Health and Family Services, the University of Kentucky Research Foundation, the Pritchard Committee, and Pew. Next slide. Kentucky does receive funding from the Federal Maternal, Infant, and Early Childhood Home Visiting Program. We've been a recipient since 2011. McV funding supports the expansion of HANDS services to multi-gravida families, allowing us to serve more than first-time parents. And it also supports Kentucky's efforts to improve coordination of comprehensive early childhood services at the local level. Next slide. The map here shows the 29 counties that are supported by the McV, and those counties are in yellow. Counties in white are able to serve multi-gravida families with state general funds. Next slide. So how did Kentucky get Medicaid to agree to finance home visiting services? I should start by saying that Medicaid has been a key player of HANDS home visiting services through targeted case management since 2011. When we look back at the history of HANDS, including its inception, the statewide rollout, and funding, the success of all these pieces really was due to perfect timing in so many areas, and most importantly, strong collaborative partnerships on many fronts that were working towards a common goal. One of such partnerships was the task force between the Kentucky Cabinet for Health Services and the Kentucky Cabinet for Family Services that was developed in 1998 to address Kentucky's top concerns for families and children. The top concerns identified by this group included child abuse and neglect, teen pregnancy, substance abuse, as well as other various high-risk behaviors. The task force decided that a home visitation program could address these concerns. In order to capitalize on systems that were already in place, the decision was made to redesign and expand an existing home visitation program called Resource Moms that visited with young families on a monthly basis until their child turned 1 year of age, to a program that provided intensive weekly home visitation that would serve all eligible first-time parents, regardless of income, beginning prenatally and extend into the child's second birthday. Next slide, please. This program was called HANDS, and in 1999, 15 pilot sites were chosen in selected high-risk areas to begin implementing it. As services were being provided by the pilot sites, a committee of representatives from the Department of Medicaid and the Department of Public Health began meeting to discuss the possibility of revising Kentucky's Medicaid plan to include home visiting services. After various meetings, the state plan was revised and submitted to the Federal Department of Health and Human Services for approval, and approval was received on July 1st, 2000. Next slide, please. During this same time, the Governor's Office of Early Childhood Development was being established to highlight early childhood concerns and address them on a state level. With Governor Patton's leadership and the efforts of many advocates, House Bill 706, also known as the Kids Now legislation, was passed in March of 2000. The legislation made it possible to use 25% of funding from the tobacco settlement dollars to support early childhood prevention and intervention programs, and HANDS was selected as one of the prevention programs supported by Kids Now, which opened up an additional funding stream to support home visitation. Again, we couldn't have asked for better timing. Next slide, please. Shortly after House Bill 706 was passed, a master agreement was developed between the Department for Public Health and the Department for Medicaid Services to support reimbursement for case management services for eligible recipients of the HANDS program. Then administrative regulations for both the Department for Public Health and Medicaid were filed and effective by December 2000. And then Kentucky began billing for Medicaid home visitation, began billing Medicaid for home visitation for prima gravida families in 2001. And we can skip the next slide due to time. All right, so what does Medicaid cover? Under the state plan, Medicaid agrees to cover the eligibility assessment, which includes a face-to-face needs assessment with the child, mother, and family. The assessment covers various risk factors associated with increased risk for child maltreatment and other adverse childhood experiences. Next slide. Medicaid also covers home visitation, which includes, but is not limited to, assisting the child and family in accessing needed services and coordinating services with other programs, monitoring progress by making referrals and performing periodic evaluations of the changing needs, and maintaining case records documenting services, progress, and referrals. In order to bill for the service, the visit must be at least 30 minutes in length. However, 45 minutes to an hour is recommended. Next slide. We do have specific provider qualifications to be able to bill for the service. So in order to bill Medicaid for the assessment, the provider must be a registered nurse or social worker, an early childhood development specialist, or have a bachelor's degree in a social or behavioral science or related field, or have an associate's degree in an early childhood education field. Next slide. Kentucky allows home visitation services to be provided by trained, we need to go back a slide, I'm sorry. Kentucky allows home visitation services to be provided by trained professionals and paraprofessionals due to cost and availability. So the qualifications to bill for a professional home visit are the same as those that provide the assessment. Next slide. And qualifications to bill for a paraprofessional home visit include a high school graduate or GED with experience in a social or other health-related field. Next slide. We also have what's called the RNSW visit, which is considered a professional visit. The RNSW visit provides quarterly visits to ensure that families meet with a professional. These visits focus on the signs of premature labor, labor and delivery, home safety, basic care, and nutrition. The qualifications of the RNSW visitor include that they must be a nurse or a social worker. So what was the argument used to convince Medicaid that home visiting should be reimbursed? Kentucky was seeking to incorporate a program that was capable of yielding measurable improvements in the lives of children and families, as well as meaningful savings to taxpayers. And the implementation of HANDS had begun as a pilot site and had gained the attention of state leads and policymakers. Since the focus of this program was improved health and social outcomes, it made sense to support the existing project, which, if achieved over time, could lead to significant cost savings for the state. And also, the ability to access federal dollars to support overburdened families and children. Next slide. Advantages of partnering with Medicaid to finance home visitation include: it has created a stable funding source for home visiting services since 2001. This unique financing mechanism has made it possible to maximize funding, allowing more families to be served regardless of income. This is due to the Kids Now legislation, which allows a portion of the tobacco settlement dollars to cover costs for both a small proportion of HANDS participants who are ineligible for Medicaid, as well as the state share of expenses for Medicaid eligible participants. Also, as previously stated, Kentucky has invested in multiple studies that document the effectiveness of hand services. Due to improved health outcomes, millions of dollars in medical costs are avoided each year. Another advantage is the simple fee-for-service billing system for reimbursement of services. Sites only have 3 service codes, one for the assessment, one for the professional visit, and one for the paraprofessional visit. Each local implementing agency enters their billable services into our HANDS web-based system, and the Kentucky Department for Public Health pulls this information from the web-based system and submits an electronic file to Medicaid for adjudication. And then Medicaid sends a remittance file back to HANDS where it's uploaded back into our web-based system and the sites are reimbursed accordingly. Next slide, please. Next slide. The only challenges that we currently face is that Medicaid coverage is restricted to first-time parents. Although we've been able to use McV funding and state general funding to provide services to multi-gravida families, these funding sources are not guaranteed beyond their budget periods, thereby creating pressure for sites regarding staff and multi-gravida caseloads. Another challenge is that families have a small window of opportunity to enroll in the program. HANDS enrollment criteria is that families can enroll during the prenatal period, but they must enroll by the time the child is 12 weeks of age. If not, they cannot participate in HANDS services. And that concludes Kentucky's experience with utilizing Medicaid to finance home visitation. Does anybody have any questions?
Yeah, thanks, Vanessa, very much. There's a few questions that came in, and we have time for that before we turn this over to Kay. So our first question is just asking about differences in reimbursement rates and paperwork for paraprofessionals versus other providers. So can you just talk about the difference in billing, including reimbursement rate and paperwork between paraprofessionals and others such as nurses?
We have a flat rate that we are able to reimburse for the assessment, one for the professional visit and one for the paraprofessional visit. So for the assessment, it's $160. For the professional visit, it's $150, and for the paraprofessional visit, it's $110. Now, that includes the visit, the time spent doing documentation, the travel to the site. It's the whole package of the service.
Great, thanks so much. Let me just look at some of our other questions. I think you talked a little bit about this already, but just how was the $23 million in avoided medical costs determined? Can you talk a little bit more about those numbers?
That was handled looking at the reduction in adverse issues with birth outcomes. We have these studies. I don't have them readily available at my fingertips since I'm in a conference room, but we can get that information to you all for sure.
Thank you. So we'll have time at the end of, thanks so much, Vanessa. We have time at the end of this webinar for additional questions, so please continue to chat questions into the chat box for our participants. Please continue to do that. I'm now going to turn this over to Kay Johnson, who's going to just Medicaid and home visiting and based upon her work in states and some of the lessons learned and resources. Kay?
Thank you very much. Can you hear me?
We can, thanks.
Good, good. Okay, so let's just skip the slide with all the cute babies and we'll move on to the content. I'm very delighted to be able to share some thoughts today. I have a great admiration for and have used, since the first NASHP report, intensively used their framing for these issues. I think for any state thinking about this issue, it's extremely helpful framing and very important state examples. I wanted to just start with some kind of takeaway messages, maybe in a little more advocacy tone, which I can have an opportunity to do. And I think the case has been very well made here that adequate financing for home visiting is going to depend on a variety of funding sources. And I've got about 12 states here, but I agree with NASHP that it's more like 15 states. And we have these various sources of funding, and it's going to take that to keep going. That's really been, with the exception of McBee, these other funding sources have been used for as long as 20 years by other states. You've heard about MIHP over a decade and HANDS over a decade, and I think that state program and policymakers and the advocates who work on maternal and child health are going to play each a very important role in securing sustainable long-term funding, and I think funding to expand. We all know we're still only serving a small portion of those families that need. And even though we didn't have the McBee reauthorization we hoped for before the end of September, bipartisan support exists for home visiting. It continues for home visiting. I think it can be cultivated at the state, national, and local level, and we all share a responsibility in doing that and making the case. NASHP's latest report points to really, I think, some of the promising practices and the trends and directions that are going to occur at home visiting financing. In Michigan's example, I've used it a lot, and they very well presented today. I think it's time we look at our traditional maternal and infant or prenatal case management programs or prenatal care coordination programs. A lot of those programs are not as robust as they used to be, or a lot of them are based on assumptions of the 1980s. And as Michigan has done, turning it into a more robust home visiting program with a curriculum, with a certification and standards for providers, with a way to serve more women, I think is one wave of the future, and there are quite a number of states out there that have an opportunity to do that. I think NASHP's pointed out the importance of finding a place for home visiting in larger systems of care, right now in managed care organizations or discussing of accountable care organizations. That's going on in Oregon and Vermont and Virginia and other places, but we've got to figure that out as we go forward. Aligning performance and outcome expectations is another theme in the NASHP report, and I think that New York is doing that. Other states have taken a look at it, and it's just simply something that our healthcare systems and Medicaid are going to demand as we go forward. And then I think engaging cities and counties in local design and financing, or local agencies, as we've heard a little bit about. An example that we haven't talked about yet today is Maryland having a adding into a Medicaid demonstration waiver a project that allows some cities and counties to apply to expand capacity beyond McBee, expand current capacity with Medicaid, and asking them to come up with a match and asking them to help design rates. So I think these are some of the waves of the future. Let me just go back on that and say again, I think that there are states, other state examples in the NASHP report that really, I don't want to ignore Kentucky HANDS, because it's not that they're not a wave of the future, but I think they point to a very important opportunity, and that is to have people do the tough evaluation work and the data collection and other work that it will take to get on the Home V McVie approval list federally. I think the other direction is what Michigan has done. Sounds like somebody put us on hold. I'm going to keep going in hopes that we can find those people. So I wanted just to talk for a moment about Medicaid and a technical assistance opportunity. And in particular, there's a technical assistance opportunity available to states in 2017-18. This builds on work I did with 11 states last year in a learning network, and on my experience with Medicaid, and on the knowledge that NASHP's collected. It's funded by the Heising-Simons Foundation that's supporting my time to provide technical assistance for up to 10 states. Much of that work will be virtual, but it's also possible to do some of it face-to-face. I've already started work with California, Louisiana, Massachusetts, New Mexico, and Rhode Island, and I look forward to talking to some other states. I've heard from a few other states this week about these opportunities, and we're really taking it from where you are to where you want to go, whether you have an existing program or you're thinking about a waiver or you're thinking about how you leverage some existing state general revenue. All of those things are opportunities for discussion. This is my email if you want to talk to me about this further or email me about it. I also want to say, just building a little, and again, a lot of the assumptions, both from the NASHP report and from the HRSA CMS interagency bulletin, are in a checklist guide for state decision making that I'd be happy to share with you if you haven't had an opportunity to see it. I think NASHP has put a lot today of those questions out there about how you make these decisions. And in some sense, what we know is if you've seen one Medicaid program, you've seen one state Medicaid program. If you've seen one state home visiting system and McBee structure, you've seen one. And if you've seen one sort of public health or safety net delivery system, you've seen one of those. And I think finding the intersection and the fit between those things is what's going to make the magic for your state if they want to use Medicaid as a part of the mix and all of that. So Karen, I'm going to stop there.
Great. Thanks so much, Kay. So now we have a good amount of time, which is by design, for some further questions. I just want to encourage, I know there's several questions in the chat box, but please continue to put those in. We may not get to all of them, and I know there's some questions that are specific questions to very specific detailed questions about the various programs that have been featured. We may not get to all of those, so you'll have the contact information if you don't get your question answered, so you can follow up directly with Suzette Marie or Vanessa. But I'm going to start out with kind of a bigger global question that I'd love for Vanessa, Suzette Marie, and even Kay for you all to weigh in on. And I think while the Kentucky and Michigan home visiting programs have their differences, and while you also have different approaches to financing, I think there's some common themes between what I was hearing from both of you, and I think especially with regard to financing, and I think some of those common elements are that you all talked about the importance of partnerships, both internal within your state agencies and also external with other stakeholders to really advancing home visiting and also financing it. You both, Kentucky and Michigan, you both talked a lot about what I would call kind of cost-benefit analyses or return on investment work that you did. So you didn't just put the home visiting program together, but there was also a lot of research and evaluation and also some real specific cost-benefit analyses to really show the impact of investments. I think you both talked about kind of a phased-in approaches to going statewide, and in many cases this just didn't happen overnight, but that it was pilots, and then those were expanded to statewide. And it sounds like you're continuing to build on your good work that's been done for many years. So those were some of the elements, and I would just ask both for Vanessa and then Suzette and Marie, in thinking about financing of home visiting, especially both Medicaid financing of home visiting services, but also using other funding streams, because that's clearly a message we're talking about here today, is that it's multiple funding streams that are used to support home visiting. I think, can you just talk a little bit more about what you see as kind of other essential elements to really helping to advance sustainable evidence-based home visiting programs within your states, and also just for other states looking to kind of really expand. And I think, so that's my first question overall, but then also if you want to reflect on that in terms of, especially we know states are really undergoing major budget constraints in many ways, and so if you want to comment on that as well, what it means to try and advance home visiting during tight fiscal times. So Suzette or Marie or Vanessa, if you could just comment on, what you see as other common elements that have been really essential to your success, that would be great. And then Kay also, if you want to comment.
This is Marie. I think that as far as common elements about advancing our programs, truly the partnerships have been the best and most important aspect of our success in our state. I mean, the MIHP program works very closely with so many different agencies, both internal and external, as we mentioned. And I think incorporating that and that relationship and those interventions, and we impart all that information and that collaboration trickled down right with the MIHP agencies and those that are out there in the home visiting arena and in that milieu. So actually moving all that information and all collaborating, I think that's been one of the great things for success. And I'll also have to say, in terms of the budget constraints and maybe advancing a program like that, I was able to put my fingers on our return on investment document that we have. There was a study in our state about the MIHP program based on 2010 data. And based on that, they took a sample of folks, or a sample of the services, and they found that the average cost of providing the prenatal MIHP services to a mom in this study sample was $517. And that was for the moms, and that averaged about 5 MIHP pre-delivery visits during the course of the program. And so they contrasted that and put that into context with the savings of what it costs for a preterm, the expenses for a preterm birth for a month post-delivery, and that was around $24,000. So putting that out together with our population, that's how we came up to the return on investment. And that is just a striking argument for anyone in our state budget areas to look at and see the promises and the benefits of our program.
Thanks so much, Marie. Suzette or Vanessa, do you have thoughts about kind of the essential elements that have been important to advancing home visiting?
Yes, this is Vanessa. In Kentucky, it's been critical to cultivate a support group of policymakers and advocates, and to keep those groups, abreast of our latest, data and, our web-based system, and being able to collect all that information so we can provide, that information. Another piece that's been critical here in Kentucky is, HANDS operates in local health departments in all 120 counties in Kentucky. And so you have those local health departments talking to their local community folks about the benefits of the program. And so you've got that grassroots effort, and that carries up to our policy makers at the state level. And that really does help us to, continue that support for, the program.
Great, thanks. Kay, did you want to comment on this? I mean, you said some of this in
yes,
your remarks.
I would like to. Thanks, Karen. And I think the other theme that you pointed out, the partnership, obviously very important, and the cultivating the relationships. But in each of these cases, again, these programs grew their own evidence base. And so I think if you're a state, New Mexico's another one with their firstborn program getting RAND to evaluate that for them. If you're a state that has a homegrown home visiting program, it's time to take a serious look at it. If you haven't, get an evaluation done. Be collecting the data you need to evaluate that program, and then be honest about whether that's the program you want to go forward with or not. In these two cases, these were successful programs, but they spent the time to do that. I think it's important to note that there are some of the national models that are being financed by Medicaid, but there again, I think Medicaid is asking for evidence about how it will work in their state, about what will be the return investment in their state. So I think the point about doing your homework, collecting your data, getting your research done, even whether you're doing a homegrown or a national model, and being able to present that and present those arguments to Medicaid is going to be very important. And these are two great examples of how that's getting done. Never too late to start that work.
Thanks, Kay. So you touched on something that actually was a question from some of our participants, and that was just, and this is to Michigan, but I think also just hearing kind of more about Medicaid financing for other evidence-based home visiting programs such as nurse-family partnerships. So I don't know if anyone, either Suzette or Marie or Vanessa, if you want to comment on kind of some of the national models and how Medicaid.
Well, in Kentucky, HANDS is the model that's used for the statewide home visitation program. We don't use other home visiting models.
Mm-hmm.
Yeah, in Michigan, I'll say the same thing. The state plan allows us to have Medicaid expenditures for the MIHP program. It doesn't currently allow for reimbursement to other areas like NFP or other programs at this time.
Karen, this is Kay. I'd just like to say clearly NFP and Healthy Families America and other national models are being financed by Medicaid in some states. And I think there was a period of time, perhaps well before McVie, a decade or 15 years ago, where a lot of people were saying, oh, only NFP could be financed with Medicaid because NFP used nurses and that was a medical health professional, and that was the way that worked. That's clearly not the case, and we're not in that world today, and states are making a lot of varied decisions. I would more throw this on to Becky. I think Becky is the one who's combed over the what states are doing most recently.
Thanks, Kay. Yeah, and I think it's just there were several questions about that. Becky, did you want to comment at all?
Yeah, I guess what we're seeing is really kind of varies by state, which we've kind of already heard from. I know in Virginia, for instance, there have different home visiting programs, NFP just being one of them that's receiving reimbursement. So it really is varying by state.
Yep, and I would refer, because we had several questions on this from participants, and I would refer you to the recent NASHP report that we showed the link, because we have other examples there of Medicaid financing of other state-based home visiting programs, including some of the national models. So there's additional details there. And clearly Michigan and in Kentucky have, kind of some more programs that have evolved over time. So Suzette and Marie, we have a question that's about, if you could just expand about, and we touched on this in our report, but I think Michigan's a really good example of this, and it's not, I think folks have a lot of questions about it. Can you just talk about financing of home visiting through EPSDT and kind of break that down for us and kind of what that means and how Michigan has approached that?
Well, under EPSDT guidelines, what happens is that the state is allowed to use, under its medical benefit, physician services and other preventive type services for the infant. And the screenings that are done in the home setting would qualify for that. The educational related aspects. So what you do is you just kind of break it down in terms of the elements of what the program delivers, and then you tie it back to state plan related services, such as, medical services, clinical services, the educational part about particular issues, health issues, and prevention. So that's primarily how it's done, at least in our state, under EPSDT.
And Karen, can I add, worth mentioning that all of the services on the required mandatory list that Becky showed and all of the services on the optional list that Becky showed are required for children under EPSDT. So case management is covered for children in every state, for example.
Exactly. Thanks, Kay. So we're getting close to the end of time. We have several questions that are very specific to actual aspects of the Michigan and HANDS models. And I'm just wondering, Kay, do you want to talk at all before I kind of delve into it, maybe a few more of those about, and also to our Suzette, Marie, and Vanessa, if any kind of kind of lessons learned, key takeaways, any recommendations for folks on the line, again, when it comes to financing of home visiting services?
So I would just say that, deciding on your purposes and whether you make your own decision tree or you use my checklist or another person's checklist, that really being very clear about your purposes and realizing that you want to start with something that's doable, and that may be a pilot or a demonstration project or an effort with a managed care organization that's just kind of a partnership that doesn't require any big change in state funding or planning or authority, although you'd want it to be under some existing authority in that case. And then thinking about, like the decision tree of, are you going to do this on a managed care or fee-for-service basis? Are you going to do this with a state plan amendment, existing authority, or a waiver? I think a lot of states are thinking they have to jump to a waiver, and it's an awful lot of effort and probably easier to do either existing authority or a state plan amendment. And then, of course, thinking about where the money is going to come from. There's existing match and existing prenatal case management programs in other existing efforts, or sometimes just where state general revenue is being used to fund home visiting, but it's never been matched with a federal dollar. So thinking creatively about where the dollars are coming from, and obviously having the partnerships between the people who lead McPhee, the people who lead maternal and child health, the people who lead in Medicaid, some of your provider agencies and your advocates to make sure that you have the relationships that have been described here is so important in going forward.
Thanks, Kay. Vanessa, Suzette, Marie, do you have any kind of final thoughts for our listeners in terms of any key takeaways or any recommendations for colleagues in other states?
This is Suzette, and I just want to reiterate some of the things that Kay and Marie had said. The collaborations are so important to successfully administer these programs and make sure that our moms and babies in Michigan, for us, the moms and babies are getting the care that they need. And I also want to reiterate the importance of quality improvement and how that must be implemented in the program to make it grow and to make sure that we're always providing the quality of service that moms and babies deserve.
This is Vanessa. For Kentucky, aside from the strong collaborative partnerships that we have had throughout the years here, I would say is our web-based system. It's our data collection system. I mean, there's this program without that would not have been so successful because we've been able to show, what we've done and been able to pull that information to do studies. To show these fabulous outcomes that we have. So I would strongly encourage states, if you don't have a data system already in place, a web-based system, that's something that should be a priority for sure.
Great. Well, thank you so much. We're getting close to the end of time. I know we did not get through all of the questions. We have a lot of questions from participants that are specific, like very detailed questions about aspects of the HANDS program or the MIHP program, questions about, the types of visits and such. And I think I'd like to just encourage those folks who didn't get those questions asked that are really specific to the program themselves to we will be posting these slides at the end and making sure you get a copy of all the slides, and then for you to contact Vanessa or Suzette and Marie directly to get some real, to get answers to your detailed questions about the actual focus of the program. We really tried to make this webinar more about, how states are financing it, and hope that, you got some of your questions answered about the financing of home visiting. So with that, if I could have the next slide. I just want to take a moment to thank our presenters. Thank you to Vanessa, Suzetta, Marie, and Kay for taking time out of your busy schedules to present today. Thanks to our participants for joining us. And again, if you have other questions, please send those to our state folks, or you can send those to NASHP, and we'll try to get your questions answered. And again, the slides for this webinar, along with other resources, are going to be sent out to all participants via email. On this slide are the links again, and you'll get these, so you can have them to the two reports that NASHP the one we just released and our one from 2012. And I think many of the questions will, especially with regard to national examples of states financing, for instance, national programs are in that report. So I would encourage everyone to look at that report that was released. And with that, also, please, if you can, take a few minutes to fill out the brief evaluation at the end of the webinar. We really use your comments and your input to really hone and refine how we do these webinars. So again, want to thank everyone for your time, and have a good rest of your day. Thank you so much.